Hello, everyone, and welcome to today's Council on Black Health webinar entitled Optimizing Brain Health Care for the Prevention of Cognitive Decline and Maintenance of Cognitive Function, the Brain Health Advocacy Mission Study. Today's presentation is offered by the Council's Solutions to Diabetes in Black Americans Core. This core is part of the NIH-funded Center for Diabetes Translation Research at the Washington University in St. Louis. The Solutions to Diabetes in Black Americans Core provides methodological and content expertise to advance the field of diabetes research in Black Americans. We appreciate you joining us this afternoon. My name is Tiffany Eaton. I am the Associate Director of Practice and Research for Women's Health with the Council on Black Health and the Associate Director of the SDDA Core. I will be your moderator today. The Council's mission is to develop and promote solutions that achieve healthy Black communities. We leverage the credibility and perspectives of Black American researchers, other collaborators, and research partners to facilitate relevant, community-engaged, actionable solutions that positively impact Black communities. Today's webinar will discuss disparities in the aging population, the impact of diabetes on brain health and cognitive well-being, and we will learn more about the Brain Health Advocacy Mission study in primary care settings. During the presentation, we ask that you post questions using the chat, and we will select those questions for the Q&A portion at the end. Today's presentation will be recorded and published online for future viewing. So we have two amazing presenters this afternoon. Our first co-presenter is Dr. Olivia Affuso. Dr. Affuso is, there we go. Thank you. Dr. Affuso is an epidemiologist and the Director of Strategic Leadership Initiatives for the Council on Black Health, where she leads the development of training programs to support the next generation of scholars, advocates, and community practitioners. In addition, Dr. Affuso conducts research that focuses on the prevention of obesity and chronic disease through physical activity interventions. Her projects include the examination of potential mechanisms of group engagement and sustainable physical activity among Black women, and the development of physical activity interventions targeting the social environments of women. Dr. Affuso obtained her PhD in nutrition epidemiology from the University of North Carolina at Chapel Hill. She also completed a postdoctoral fellowship in the Department of Exercise and Sports Sciences at the University of Miami. Our second co-presenter today is Dr. Pamela Bowen. Dr. Bowen is a certified family nurse practitioner, scientist, associate professor, and researcher at the University of Alabama at Birmingham School of Nursing. Dr. Bowen serves as clinical director for the Evelyn F. McKnight Brain Institute's Brain Health Advocacy Mission, which strives to engage, educate, and empower individuals in primary care clinics from all aspects of life to improve and maintain their cognitive health. Obesity-related chronic diseases are prevalent among people of color and those from low-income backgrounds who make up Dr. Bowen's primary patient population. Promoting mental and physical health, in her opinion, requires the adoption of healthy behaviors, even if they are difficult to implement. Dr. Bowen acknowledges the challenges that individuals encounter when attempting to adopt healthier lifestyle habits. Consequently, her team believes that establishing BHAM as a resource within primary care clinics to support primary care patients in their journey towards better health as they age is a promising strategy to preserve overall brain health. So with our two co-presenters, we're going to start with Dr. Olivia Affuso. So Dr. Affuso, I now invite you to proceed.
Thank you, everyone, for joining us. So I'm going to set the stage for why we should think about brain health, particularly in the context of an increase in the prevalence of diabetes within our population. And first, I will start here with showing these three population pyramids from the United States between the years 2000 and 2020. Both the size and the shape of the nature's populations have changed in the past 2 decades. And what we can see is that the pyramid was much larger in 2020 compared to the 2 previous decades. This reflects a growth in the US population up 22.7 million, or about 7%, for a total US population of approximately 331 million people. The population has also aged since 2000. And what we can see from these population pyramids is that we have an increase in the number of individuals that are over the age of 65, while at the same time, we have the bottom of the pyramids getting smaller. And the reason that the pyramids are getting smaller, that we see this decrease, is because we're having fewer births within the United States. So in this graphics, we can see that the US population age 35 and older has grown nearly 5 times faster than the US population over 100 years ago, according to the 2020 census. And the older population has reached 55.8 million individuals, with approximately 16.8% of the population being over the age of 65 in 2020. So because we have this decline in fertility, which equates to having fewer births, we've seen the age structure of our population declining such that we have more individuals over the age of 65 than we have children under the age of 18. So if we continue at this rate of growth in our population, we will have more than 30% of our population being over the age of 65 by the end of the century. So when we look at the US Black population, what we see that the pyramid is different. The Black population is actually younger. So the median age of the Black people in 2022 was about 32.1 years, which is nearly 6 years younger than the entire US population mean age, which is approximately 38 years. And roughly 30% of the entire Black population is below the age of 20, while 12% of the Black population is 65 and older, compared to 16.8% of the US population. So we have this increase in a shift in our minority populations, according to the US Census, such that minority populations are outpacing the growth of non-Hispanic white individuals in the coming decades. So approximately 45% of the US population age 65 and older will be from minority groups by 2060. And African Americans represent one of the highest increases in population growth that we can expect to see during that time period, with almost a 200% increase in the Black population in the US relative to other race ethnic groups. So what does this mean for the landscape of brain health? I'm going to start here by doing a little bit of level setting around the terminology, which can be quite confusing in this area talking about brain health. So first of all, cognitive impairment is a condition that affects a person's ability to think, learn, remember, make decisions, and use good judgment. Cognitive impairment can range from mild to severe, and it can impact a person's ability to live independently. And also, cognitive health is just one aspect of overall brain health. So dementia is also another term that you will hear widely used, but it is actually not a specific disease, but rather a more general term that talks about impaired ability to remember, think, and make decisions. So in more detail, people with dementia have problems with memory, attention, communication, ability to make good judgment. They may also have some visual perception beyond typical age-related changes in vision. And some of the signs include getting lost in a familiar neighborhood, using unusual words to refer to familiar objects, forgetting the names of close family and relatives or friends, forgetting old memories, and not being able to complete tasks independently. So some of the risk factors for dementia include age, family history, race, ethnicity, poor heart health, and traumatic brain injury. And so what we know is that people with diabetes have about a 60% increased risk of developing dementia compared to people without the disease. And diabetes is linked to other dementia risk factors. So someone with diabetes is more likely to have high blood pressure, high cholesterol, and obesity. So we see these clustering of chronic diseases together that further to increase the risk of Alzheimer's among people with diabetes. And some of the changes that occur in Alzheimer's disease are similar to those in diabetes. In both situations, nerve cells in the brain may become resistant to the effects of insulin and may lead to a buildup of plaques in the brain. And Alzheimer's disease is sometimes unofficially known as type 3 diabetes. So one of the things in particular we should note here is older African Americans are twice as likely to have dementia than whites. So Alzheimer's disease is the most common type of dementia, and it's estimated that 5.6 million Americans aged 65 and older have Alzheimer's disease and related dementias. There are fewer individuals that have young onset Alzheimer's below the age of 65. And it's not clear if there are racial or ethnic differences in younger onset Alzheimer's disease in terms of data that's available. However, by 2060, the number of Alzheimer's disease cases is predicted to rise to an estimated 14 million people. And Alzheimer's disease is a neurodegenerative disorder that has progressive impairment of behavioral and cognitive functions. And as I stated before, minorities are at a higher risk of Alzheimer's disease due to the higher levels of heart disease and diabetes. Furthermore, we see women at higher risk of developing Alzheimer's disease due to the fact that they live longer. So now we have an intersection of race and gender that put Black women at increased risk of developing Alzheimer's disease. So according to these new estimates of Alzheimer's disease and related dementias, we show that cases among African Americans are expected to increase 4 times over the current estimates by 2060, such that 14% of adult African Americans over the age of 65 are expected to develop Alzheimer's disease. So in looking further at the data, there have been a couple of studies to look at, why there might be these differences in the prevalence of Alzheimer's disease. One study that was conducted by the Pfizer Foundation found that there was an increased incident of Alzheimer's disease among Blacks with 26.2 per thousand, showing a greater rate of incidence of Alzheimer's disease compared to whites, which was 19.3 cases per thousand in the population compared to non-Hispanic whites. Overall, they projected that 38% of African Americans greater than 65 years of age will develop Alzheimer's disease in the next 25 years. This was a landmark study because prior to this study being conducted by the Pfizer Foundation, no other study had looked at a diverse group of individuals to be able to see the race and ethnic disparities that are prevalent for this disease. There was also one additional study recently published in 2022 that analyzed data from the National Coordinating Center of Alzheimer's Disease that included 5,700 Blacks. And what they found was that 27% of the study participants had been diagnosed with Alzheimer's disease compared to a lesser number among whites. This study also pointed out that Blacks were less likely to be diagnosed of Alzheimer's disease at the first clinical encounter. And they also found that when they were diagnosed, African Americans were found to be in a later stage of the disease with a much greater severity of Alzheimer's disease compared to white patients. So all of these data really set the stage for why it's important that we really take a closer look at brain health earlier in primary care to be able to provide a better quality of care and reduce the risk of the development of Alzheimer's disease and related dementias. So with that, I will pass it forward to Dr. Bowen to talk to us about her area of research.
Thank you, Dr. Affuso, and I want to thank everyone for coming to this session. And so for my portion of this webinar, I would like to discuss the Brain Health Advocacy Mission initiative that we're doing in primary care clinics. And I also provide a few takeaways related to brain health care and primary care at the end. So first of all, in 2017, just to give you a little background, in 2017, the American Heart Association and the American Stroke Association, they issued a presidential advisory that included the Life Simple 7 framework strategy. And that's where they operationally defined in quantifiable terms what brain health meant. And they also provided suggested therapeutic targets that people can meet in order to prevent or manage chronic conditions. And in 2021, the American Heart Association, they published a scientific statement, and it was entitled the Primary Care Agenda for Brain Health. And this was chaired by Dr. Ronald Lazar, who is one of my colleagues, and he is also the director of the UAB McKnight Brain Health Institute here. Well, this statement, it amplified the Life Simple 7 framework in order to include the alcohol assessment of alcohol consumption of a person, their social engagement, hearing, and their mood. And all of this data show that if you don't control risk factors early in life, these will affect your cognitive functions later in life. So the definition of brain health, there's no one definition for brain health, and it's a growing concept. And the working definition that she and her colleagues have developed is a lifelong, multidimensional, dynamic state consisting of cognitive, emotional, and motor domains underpinned by physiological processes and can be objectively measured and subjectively experienced. And so I know that's a long definition, but it's all encompassing of everything that impacts brain health. And it's also important to remember that social, biological, psychological, and ecological factors also impacts brain health, just as living with diabetes does. So as healthcare providers, we are very familiar with type 1 diabetes and type 2 diabetes. But I would also like to mention briefly type 3 diabetes, like Dr. Affuso just did. But it's important for you to know that it is not recognized by national health organizations, nor is it recognized by the American Diabetes Association. And the culprit appears to be the Alzheimer's gene variant known as ApoE4, which is found in 20% of the general population, and is also found in more than half of the patients who are diagnosed with Alzheimer's disease. It is responsible for interfering with how neurons in the brain handles and responds to insulin, which is essential for basic tasks like memory and learning. And some researchers believe that it is caused by insulin resistance or insulin-like growth factor malfunction in the brain, which can cause or trigger Alzheimer's disease. However, even though there is some science behind this claim, it's too oversimplified to say that this is actually a fact. We know that over time, untreated diabetes can cause damage to blood vessels of the body. These same things can happen to blood vessels in the brain. And many people with type 2 diabetes may not even know they have the condition, and this can delay the diagnosis and the treatment, which can lead to further damage to the brain. So what is the connection between diabetes and the brain? Well, more research needs to be done in order to understand these possible links of diabetes and the development of Alzheimer's disease. Diabetes can affect the brain because it is sensitive to hyper and hypoglycemia, which can cause damage to the nerves and the blood vessels in the brain. So it's very important that we increase the awareness of our patients of the importance of keeping their diabetes under control, because the same way diabetes can damage nerves and blood vessels in your eyes and your feet, the same things are happening to the blood vessels of the brain, which over time can lead to memory loss, learning problems, and potentially the person can develop cognitive decline or Alzheimer's disease. So it's important to stress diabetes management is needed to keep on target for not only the body, but the brain as well. And the best way to do that is with a healthy lifestyle. So what is a healthy lifestyle? A healthy lifestyle includes activities and habits that promote overall physical, mental, spiritual well-being, all while lowering the risk of serious health conditions. And although there is no effective treatment or proven treatment or ways to prevent Alzheimer's disease or related dementias, maintaining a healthy lifestyle is crucial for healthy aging and for the management, prevention, and delay of chronic conditions, including cognitive decline. So why is a healthy lifestyle important or beneficial? Living a healthy lifestyle can reduce various diseases, chronic diseases, even those that runs in families. If you live a healthy lifestyle, you may be able to decrease the number of times you have to go and see your healthcare provider. You may be able to decrease the amount of medications that you have to purchase. If you have a smaller weight, you can buy smaller clothes, which costs less money. Better health leads to a better quality of life. And living a healthy lifestyle can also be good for the environment. And so you might be thinking, well, how can living a healthy lifestyle be good for the environment? Well, ultra processed foods, foods like cheese puffs and those dessert cakes that are packaged, chicken nuggets, cereals that are sweetened, all of those are processed foods. And more than 70% of foods in the US supermarkets are ultra processed. And this process contributes to greenhouse gas emissions, water insufficiencies, plastic waste, and it leads to the destruction of our forests. Here in Alabama, the reason why we were really stressing a healthy lifestyle is related to the obesity rates. As you can see, Alabama has a obesity prevalence of 35 to 40%. And Jefferson County, where I am, they obesity ranks 35%. Physical inactivity is also a major issue here in Alabama. And you can see 7 states in dark red: West Virginia, Louisiana, Alabama, Kentucky, Arkansas, and Mississippi. All of these states have a physical inactivity prevalence of 30% or more. And regionally, you can see that states in the South has the highest, it's at 27.5%, and it's followed by the Midwest at 25%, Northeast at 24%, and then the West at 21%. All of this brings us to the BHAM study, or our project. And so what's unique about the BHAM study is that we do our brain health visit when patients go to their primary care visits. So they go and see their primary care health provider, and then we see them immediately after they see their primary health care provider. So it's a clinic within a clinic. It's basically how we say it. And we try to do this, scheduling this way, in order to decrease the burden of adding a separate visit for our services to the patients. We also think that primary care is one of the ideal settings for practice-based efforts in order to prevent or delay cognitive decline. Research suggests that the sooner a person makes the necessary lifestyle changes to promote good health, the better. Good brain health, the better. Our project encourages our patients to make informed decisions about their overall health in order to improve their brain health. And so we incorporated the American Heart Association Life Simple 7 as a guideline and a strategy for improving cardiovascular health and brain health. But I just wanted to note that Life Essential 8 became available after we started the project, but we do incorporate some of the things that are now in Life Essential 8. So again, the American Heart Association Life Simple 7, this framework focuses on 7 lifestyle targets. So we talk to the patients about their blood pressure, cholesterol, blood sugar, physical activity levels, their diet, their weight, and their smoking status. So all of these target factors here are modifiable. So we talk to the patients about these first. Other factors that can impact your brain health is our alcohol consumption, sleep disturbances, social engagement, hearing loss, and mood or anxiety or depression. So how are we addressing brain health through brain care? Well, the research team at the McCants Center for Brain Health at Mass General and Harvard, they developed the McCants Brain Care Score tool. And you can scan this QR code and you can go in and evaluate your own brain health. And so they believe that using this tool will answer a key question in a scientific way. What can one do to take good care of their brain? And so their research mission is to identify indicators of brain health and discover interventions that can prevent the brain disease. And so their mission aligned greatly with the BHAM's mission, and that's why we incorporated this tool. The tool has 3 components. There's a physical component, a lifestyle component, and a social emotional component. And it assesses what the person is already doing to protect and maintain their heart and brain health. And then we see what areas that need to be improved, and we discuss those. I also want to note here that when we first started the BHAM project, the tool was 0 to 15, but now this tool has been validated at 0 to 21. And it's much better this way because nothing is black and white for people. And so this gives a better assessment of what the person is doing for their brain health. So that's why it changed to 0 to 21. And the higher the score, the better. the tool doesn't say if I score 18, that means you're very good. It just means it's giving you a gauge. The higher the score, the better you are living a healthy lifestyle or doing things to protect your brain health. So the physical components or metrics of this brain care tool, it assesses the person's blood pressure, glucose, or really their hemoglobin A1C, cholesterol levels, and their body mass index. The lifestyle metrics, we talk to the patients about their diet, their alcohol consumption, do they smoke or not, the amount of exercise they get, and we have to always make sure we let the patients know when we're talking about exercise, we're talking about when you intentionally say, I'm going to exercise and I'm where I get my heart rate up. Because a lot of times people will tell you about their jobs where they walk all day or they're physical all day, but we have to specify when you're getting your heart rate up and the amount of sleep that the person gets. And then when we assess their social, emotional metrics, we ask them, do they have social support? If something came up, would you have at least 2 people that you could talk to if you had a private matter to come up other than your spouse or your child? And then meaning of life, we want to know whether or not people feel like life has meaning and purpose, or do they struggle to find value and purpose in life? So the purposes of the BHAM study was to implement a brain health visit into 2 of our UAB family medicine clinics here, and to suggest specific therapeutic targets that we could help patients to come up with realistic goals in order to achieve improvement in whatever area they decide they would like to work on. Inclusion criteria, the person has to be 18 years of older and generally healthy. In other words, they can't have had a stroke or anything that has impaired their cognitive function. They must receive medical care at the 2 UAB primary clinics. We are hoping that we can expand to other clinics, but we had to start off with 2. They had to be able to speak English and be able to read English. Exclusion criteria, mild cognitive impairment or dementia, severe psychiatric disorders, resistant hypertension, have had a stroke or cancer. So we recruited 100 participants. They were either in 2 groups. They would be randomized into group 1 or group 2. They had to be able to participate for a year. Depending on which group you were in, you would get 3 sessions. If you were in group 1, if you were in group 2, you'll get 5 sessions. And quantitative data would be used to evaluate the program. And this right here is just a screenshot to kind of show you what happened in group 1 and what happened in group 2. So participants in group 1, they received less contact from us. So we did a baseline assessment with them. We went over the brain care score tool. We did a finger stick blood sugar and total cholesterol. In 6 months, they would get a telephone call. In 12 months, they would do everything that we did in the baseline group. Whereas in group 2, they had more contact. They would get a baseline visit, a phone call at 3 months, in-person visit at 6 months, and then at 9 months, a phone call, and at 12 months, they would get an in-person visit. So once we obtained informed consent and we went through the whole brain care score tool and we entered data into our REDCap database, we would share with the patient which areas we would see that needed to be improved in order to improve their brain health score. And so they could choose from, I want to work on my blood pressure, my cholesterol, my exercise, my diet. I want to increase stop smoking. I want to improve my BMI. I want to increase the amount of sleep. I want to decrease my anxiety. So they could choose whichever ones they wanted to work on. And even if we as healthcare providers would see something that we would rather for them to work on, if they chose, I'd rather work on my weight and their blood pressure is high, we had to work on what they wanted to. And the premise behind that is if they choose a target area that they would want to work on, they would more likely do it versus us telling them what to work on. And we would help them to come up with realistic goals that they could incorporate into their daily routine. For example, I had a patient come in and she said that she wanted to work on her weight. And she said, I said, okay, so how much weight do you want to lose? She wants to lose 50 pounds. And I said, okay, so when do you want to, how long you think that this should take? I want to lose it in 2 months. Wait a minute, that is unrealistic. And then we have to go through telling them about what lose weight slowly. You didn't gain 50 pounds in 2 months. You shouldn't lose 50 pounds in 2 months. And then they eventually kind of come around to it and try to stretch out how long it would take. But we try to get them to make slow, small steps because we feel like if they can see some wins along the way, they'll be more likely to continue on this journey. But it has to be realistic in the beginning. And so these are just the baseline results. From this slide, you can see that the mean age of our participants and our 100 participants was 46. The majority of our sample was African American and female. But the one good thing about the demographics in this cohort is that we're reaching the middle age group, and the research suggests that changes that you make middle age and earlier, the better for your brain health when you get older. From this slide, you can see that the past medical history of our participants, and the top 3 were hypertension, followed by anxiety, followed by hyperlipidemia. So based on the race and the composition of our population, we kind of figured that we would see the hypertension and the hyperlipidemia, but the unexpected finding we found was the anxiety diagnoses. So when we looked at blood pressure, the mean blood pressure was 127/83. And we can see that over half of the population falls in the elevated and the hypertension categories for both systolic and diastolic blood pressure. The mean glucose for our cohort was 104, but it's important for me to let you know that these blood sugars were not fasting. Most of the times these were afternoon visits, so the participants have had lunch and breakfast by the time they come in. Now, the hemoglobin A1C range was 5.2, which means that the majority of our sample A1C was less than 5.7, which was good. The mean cholesterol, and it's important to know that it was total cholesterol that we did. It wasn't the breakdown, but the mean cholesterol for this population was 184. And the mean BMI for our population was 33. Now, although the higher the brain care score, the better the patient overall brain care was, the mean score for our sample was 9. And so, but for this one, remember, we did the 0 to 15. The new tool that you all have access to is 21. But for the first 2, it was 9. So based on the brain care score tool of the participants, the top 3 suboptimal criteria were BMI, blood pressure, and physical activity. These were the top 3 things that people could improve on or choose to work on. So when the patients were advised of what those suboptimal criteria were based on their brain care score, to the top 3 that they chose to work on were exercise, weight, and diet. What we know is that the brain, when people start exhibiting problems with concentration and memory loss, the brain has been changing 20 to 30 years before you start to see those changes. That's why it is so important to start discussing living a healthy lifestyle with our patients young. Really, it should even start at pregnancy. That's how far back we really need to start talking about healthy lifestyle in order to preserve our brain health. So this presents a window of opportunity for healthcare providers to discuss healthy lifestyles as it relates to brain health. And research suggests that a lot of times doing one thing, like focusing on sleep or just focusing on weight or just focus on one thing, most people are going to need to focus on a combination of things. So this research by Dana in 2020, it showed that people who focused on physical activity, not smoking, limiting alcohol consumption, eating a healthy diet, engaged in social engagement activities, they were more likely to decrease their risk for Alzheimer's disease by 27%. What we learned from our study was that 28% of our cohort had a diagnosis of anxiety, but only 2 out of the group selected anxiety as something to work on. And we all know that stress and anxiety can impact blood pressure. It can impact what you eat, your diet. It can impact whether or not you feel like exercising. It can impact a lot of things. But so anxiety is something that we as healthcare providers need to kind of talk to our participants about. Many of our participants chose exercise as their primary target to work on, behavior to work on. They all, the majority of them felt like they needed to increase their activity, intentional activity. They wanted to lower their weight and work on their diet. And all of those things kind of work together. We pay our participants for participating in a study, and we use a CLIN card system. And we found that a lot of people are kind of hesitant to give their social security number. So that's, if you wanted to engage in that kind of, in this kind of project, that's something you might need to think about, monetary incentives. And we found that patients, the majority of them said they would have rather had some kind of contact monthly, whether it's by, well, most of them said by text, in order to motivate them to stay on track, and to text as far as getting reminders about their upcoming visits. They'd rather have text messages because it's quick. They can respond later. They don't have to answer the phone, because we were doing a lot of phone calls. So the strengths and limitations to our project, the limitations are that it was a convenient sample. We only used UAB, Hoover, and Highlands. The patients had to have insurance in order to participate, but that means we have missed people who don't have insurance or have limited insurance. Our recruitment only occurred on Tuesdays and Wednesday afternoons, which means there were 3 other days that we missed. And it was self-reported progress, which means that they could have inflated what their progress was. But the strengths were that we provided individualized, tailored healthy lifestyle sessions with each participant. We met the participant where they were. So we found out what they were doing, what they were currently doing, what were the barriers, facilitators, and try to help them come up with things that they can do naturally every day. We had healthcare provider buy-in. There was no cost, monetary costs for the patients. We didn't bill their insurance. And the baseline visits corresponded with their regular scheduled healthcare visit, which meant that they were already there, so they didn't have to do an extra visit. So our next steps, we are in the process of publishing our results, and we have started to enroll into a BHAM registry in order to have some longitudinal data. So the takeaways are that type 3 diabetes, that's highly controversial, and more research is needed in order to see what the link is between diabetes and Alzheimer's disease. But there is a possible linkage between insulin resistance and insulin-like growth factor dysfunction in the brain that can lead to Alzheimer's disease. And then what I really want to talk about is brain health is so important that we discuss with our patients that living a healthy lifestyle can help with their brain health, as well as help with their heart health and help with their diabetes. So it's important that we try to promote healthy lifestyle behaviors across the lifespan. Even in our busy clinics, I know there are busy clinics, but it's so important to stress the importance of doing something on a daily basis versus trying to do something with a quick fix. These are my references, and I'd like to acknowledge the Evelyn McKnight Brain Institute for funding this project, as well as the McCann Center for the Brain Care Score 2. These are the people that's on our team, and that's it.
Awesome, thank you. So thank you again, Dr. Affuso and Dr. Bowen. So I'd like to invite our participants to post questions using the Q&A feature or in the chat. To start, Dr. Bowen, earlier you shared that brain care scare tool, and you talked a little bit about the role of primary care providers, but how can primary care providers use this tool in their own practices or clinics?
Oh, thank you for that question. So what you can do, you can have those on little postcards, or you can have it, printed out and have it in the exam rooms, and just ask the participants or your patients to scan it and to go in, and they can do a self-assessment. And then that would give them something to discuss with you during your visit. I would also advise our healthcare providers, their staff, I would advise anybody to take that tool to assess their own brain health, brain health care. And we pass it out to the churches. Everyone needs to know about brain health because people are living longer, but we want to have quality of life, not just quantity. And it's free.
And that's, we might have to ask you to put the QR code back up for folks so they can capture that just in case.
Okay.
And another question, why do you think participants chose physical activity, weight, and diet as their primary targets?
Well, because most of the people were either overweight or in the obese category. And surprisingly, well, not surprisingly, most people know what they need to work on even before they come in there. The thing is, it's the motivational piece that's missing. They need someone to help them to strategize what they need to do. A lot of, in a previous study that I conducted, the participants thought they didn't know that they were classified as obese. They thought they were classified as overweight. So for some people, that's an eye opener for them. But then for some, they say, yeah, my doctor told me I need to lose weight. He just told me to exercise and eat right. but they don't give them any details. People need to have details and examples and in order to kind of see how it can relate to their actual lifestyle situations. Does that make sense?
No, that definitely does. Thank you. We have another question. Did you provide any assistance to participants with overcoming family or community level barriers to following the health advice they were getting from the study?
Yes, so if that was a barrier, if they said that was something was a barrier, childcare, or if they mentioned something was a barrier to whichever target they chose or selected, then we would talk to them individually about ways they can overcome that barrier. Everybody had something different. So if someone says, I'm a single parent, I have to take my child to soccer practice after school, and then when soccer practice is over, I have to come back and help with homework, so I don't have time to exercise. I would suggest while your child is out there playing soccer, you can walk around the track while they're practicing soccer, and you're able to get your activity in while your child is getting their activity in. And then when y'all finish, then you can go home and do the homework. There's always small things that they can do. You just have to work with each person to see how you can overcome those barriers. I even suggest YouTube videos. There's YouTube videos with different times, amount of times. They have some for 10 minutes, 15 minutes. There's always something you can do if you're trying to increase your activity. It's just getting them or showing them where those resources are, or giving them examples of things that they can do. That's realistic.
Thank you. We have another question. Are you familiar with programs that combine cognitive enhancing strategies and physical activity to improve brain health?
No, I'm not familiar with any specific programs. Are they telling me about one or want to share one that's available?
I think it was more if you know of any that are available that can be used.
Oh, okay. No, I'm not aware of, those. I'm sure it's probably some out there.
And then we have one more question in the chat. You mentioned that individuals with certain psychiatric illnesses were excluded from the study. Could you share what that criteria was?
Yeah, so like if they have bipolar or schizophrenia diagnosis, those are they're excluded from the study because they've already had changes to their brain already done. And that's why they were excluded. So same thing if they had a stroke already, if they have hypertension that's that's resistant to medical treatment, those patients would be excluded. The premise is they've already had changes done to their brain already.
Okay, got it. And then I know one of the next steps was for allowing for the longitudinal assessments and to follow up with folks longer term. What does the current follow-up look like in terms of those who are enrolled those enrolled in the study, after the 12-month period? Is there any sort of follow-up that happens, whether 6 months later, year, like how long are you following those enrolled in the study?
Okay, so the project that I just told you about, that one's over. That was basically our pilot study so that we can see, was it feasible to even do this program in the clinics and see if we could work out some kinks. But now that we're enrolling into the longitudinal study, we will do follow-up every 6 months. And we just submitted an addendum to the IRB so that we can send motivational text messages at least once a month, since a lot of the participants said they believe that would have helped. I think it has something to do with them feeling that they have an accountability issue. So if they get the text message, it kind of reminds them, okay, they're going to check with me to see if I'm meeting my goals at my next follow-up visit, which would be 6 months. So it's every 6 months they will either get an in-person visit or a phone visit. And they get paid for both.
Awesome. And I think just one last question. You mentioned some of the barriers that folks experience. What sort of cultural adaptations have or were incorporated in that pilot in terms of the recommendations, in terms of the curriculum? Like what sorts of cultural adaptations or strategies did you all use?
So we're using Life Essential 8 as our guide, but the adaptations come from the individual sessions. It's going to be based on the patient's preferences. So we let them lead us as to how we modify things. We give them the strategies. They tell us whether or not that's going to work or not. And then we try to come up with what works best for them.
Okay, awesome. And then last question for you for today. Any plan to do objective measurements of weight or physical activity, et cetera?
So we get their weight at every in-person visit. We do get their weight, their physical activity levels. We get all of that at each in-person visit. The thing is, we only focus on what they decide to focus on. So if weight is something that we as healthcare providers think they should focus on, but they say, no, I want to focus on sleep, that's where we put our attention to help them to address sleep. We let them determine how or what they will focus on. Because what's important to them is not important to us.
Got it. So it's more patient-led for those.
It's patient-led.
Awesome. And so those were all the questions that we have. And again, I want to thank you both, Dr. Affuso and Dr. Bowen, for this informative presentation and for providing us the background on disparities in the aging population, the impact of diabetes on brain health, and sharing the findings from the Brain Health Advocacy Mission study. On behalf of the Council on Black Health and the Solutions to Diabetes in Black Americans Core, I would also like to thank our attendees for participating in today's webinar. We will be sharing an evaluation survey with all attendees shortly. I hope you all have a wonderful afternoon and take care, everyone.